Welcome, and thank you for joining us for this MyIBD virtual program, Thriving with Long-Term IBD. Hi, everyone. My name is Gary Jacobson. A quick bit about me. I'm 63 years old, and I've had Crohn's disease for over 40 years. I guess that makes me a bit of an expert. Handfuls of daily pills, weekly injections, monthly infusions, and annual surgeries. I thought I had experienced it all. What I've noticed is in the past decade, I've had new symptoms. I've had fistulas, osteopenia, and dysplasia. And we're going to talk about some of those later on. I joined the CCFA as a volunteer 25 years ago and has worked on many projects with them over that time period. I hope that you all find this program very helpful. Whether you or a loved one is diagnosed with IBD at a young age or later in life, IBD is a long-time disease and it can be debilitating. It affects your quality of life. Tonight, we plan to have some insight and empowering discussion on thriving with long-term IBD so you can get a deeper understanding and the evolving needs as you get older. In order to make this program a little more interactive and find out how much you've learned tonight, we're asking two questions at the beginning of this. We're going to take a poll. Let's start with tonight's first question. True or false? There is a lack of IBD therapies approved specifically for children. Please answer in the pop-up box that just came onto your screen. The second question directly underneath is, which age group listed below has the greatest number of patients living with IBD in the USA today? I'll give everybody a couple of seconds to answer and pick their selections. At the end of the presentation, we'll ask these questions again and see how much the group has learned over the time period. Thank you for participating. It looks like most people have put in their selections. And for question one, most of you say true. 72% of you are saying true, while 28% said false. And for the age group, there's a little bit of a surprise here. The age group with the most people in it is the 20 to 29-year-old group, followed by the 40 to 49-year-old group, the 50 to 59-year-old group, and then the over 65 selection. So wait, let's get this box. Thank you for getting the box off. On behalf of the Crohn's and Colitis Foundation, I want to thank you for joining us tonight. The information, a little bit of disclosure stuff here. The information shared tonight is meant to be for educational purposes and should not replace any advice or guidance from your own healthcare professionals. Talk to your doctors. I've found over the years that's the best way to learn and try to get things done. This program will be recorded and posted to the MyIBD Learning website, www.crohnscolitisfoundation.org/MyIBD Learning, and everyone who is registered for the program tonight will receive a link to it over the next week. We want you to think of this as interactive and engaging for you, so we encourage you to submit your questions along the way in the question and answer box, which can be found in the lower part of your screen. Following our expert discussion, I will moderate a question and answer session with all of the panelists, and we will address as many of the questions as we can today. Tonight, we are very lucky to have three experts in the field of IBD. First is Dr. Rabizadeh, who has a long resume here. I'll give you the highlights of it. He is the chair in the Department of Pediatrics, the director of pediatric gastroenterology and pediatric IBD. He is the Women's Guild Distinguished Chair in Pediatrics, and all of these are at Cedars-Sinai in California. Our second doctor is Dr. Adam Fay. He's an assistant professor at the Medicine and Population Center at NYU IBD Center in New York, and he is the director of clinical research, and that's the NYU Grossman School of Medicine. Our third doctor is Dr. Haley Merton. She will be answering the questions in the box. She is a gastroenterology fellow at the University of Michigan, and she herself is an IBD patient. So I know what she's going through. Listed here are our speakers' financial disclosures. We have to do that for legal purposes. So let's get this started. You don't really want to hear me talking. You want to hear these doctors talking. At this time, I'd like to welcome our first presenter, Dr. Rabizadeh.
Thanks so much, Gary. I really appreciate the introduction and really appreciate everyone joining us tonight. So hope to give you guys a decent educational session. And what I was asked and tasked to do was to give you some discussion about pediatric inflammatory bowel disease and talk about some of the treatments and how to navigate those treatments within the children and adolescent world overall. Now, both of those topics would be multi-hour long talks, so we're going to try to consolidate that and do it all in 15 minutes or less. So let's just set the table and talk about what we're discussing, inflammatory bowel disease. So we often think about that as divided between Crohn's and ulcerative colitis, and we'll end where we're going to try to get you away from that concept overall in terms of how we should start viewing the disease entity of IBD a little bit more. We all know it's related to a dysregulated immune response in the right genetically susceptible individuals, and you can see some different incidence and prevalence numbers. But sticking to that pediatric focus overall, we're talking about somewhere up to 200,000 children who are presently believed to have IBD in the US. But what's surprising for some people to see is that 25% of those who are diagnosed with inflammatory bowel disease are in the pediatric age range group, so less than 18 years of age, usually greater than 6 years of age. And we'll talk a little bit about it, the under six, as that's a unique subgroup. Go ahead, next slide. So IBD presentation in pediatrics is similar to the adult presentation. So when you're talking about Crohn's, you're talking about the abdominal pain, weight loss. When you're talking about ulcerative colitis, you're talking about the diarrhea, the rectal bleeding. A couple of questions that always come up for us is that if I have IBD, how do I protect my children from IBD, as there is increased risk there? And we talk about those things that protect against developing IBD. If you can control it, it would be less likely if you could do it by having a vaginal delivery of a child, breastfeeding your child, limiting antibiotic exposure in the early life period overall, and of course, family history. But what makes IBD unique in the pediatric age range is the other vital sign that we consider in pediatrics. Vital signs, you think about blood pressure, heart rate, temperature. In pediatrics, if you go to the next slide, our other vital sign is actually growth. So we teach our pediatricians that when you are looking at a child who is not growing the way they should be or are expected to be, one of the things that we want them to consider is if there's inflammatory bowel disease or other inflammatory conditions that may be leading to that growth issues overall. So most pediatricians, what they'll do is we do a rudimentary calculation called a mid-parental height. That is the average of the parent's height plus or minus 5 inches for boys and girls, and then plus or minus 2 inches within whatever height that is. That's what we expect a child to be, ballpark, for their adult height. And you're looking on those growth plots to see if they're growing in that extent. But what happens with IBD, especially in Crohn's patient, is that there's a high number of patients who are not meeting what their expected height would be. But there's a lot of other conditions that could do that. And what I always teach is how to differentiate those in a big frame, looking at what could be IBD related to lead to that shorter stature versus other conditions like endocrine conditions, like problems of the thyroid or growth hormone deficiencies, or the most common, which is constitutional growth delay. That's the child who is the late bloomer, the one that was the shortest in the class until junior year, and then the summer they came back, shot up, and got taller than everybody else. Or versus genetic origins, which is that just you're genetically prone to be small. And what you highlight the difference between these conditions overall is that the IBD related patients typically, not only is their height velocity, they're growing slower than they should, but their weight is also affected. Their weight velocity of growth is also on the lower end overall. So you get a low body mass index or a low weight for height. Go ahead to the next slide. One other unique aspect of pediatric IBD is looking at this special age range group of the very early onset inflammatory bowel disease patients. This subgroup is those who are less than 6 years of age. There's even a subgroup of them who are less than 2 years of age, who are very early onset IBD. And in that subgroup right there, what you're understanding is that this is a time period that the patient has a critical and vulnerable period of initiation of the host immune responses. It's when the gut bacteria is forming, the microbiome is forming, it's interacting with the immune system, and in that interaction is how the host immune system is developing overall. In this subgroup right here, you see that these patients are much more highly likely to be associated with a genetic origin to their disease, something we call monogenic disorders, where you're seeing one genetic defect as a major factor in their disease overall. Most commonly, these patients will present with bloody diarrhea. That's whether they're that classic Crohn's or ulcerative colitis, typically they all present with bloody diarrhea, and that evolves and develops as they get older overall. But there's other causes of bloody diarrhea that are more common, like allergic colitis or infectious colitis, which we always rule out. And the implications of disease so early in life, there's a lot of factors to consider. You're starting therapies on these patients 20, 30 years earlier than others. And if so, is there going to be adverse effects of those therapies versus the natural history of the disease or the adverse effects of the disease overall? So these are big discussions to have with your healthcare providers as time goes on. Go ahead to the next slide. A little bit more about the kind of genetic aspects of the very early onset disease. You can see that top left graph, the monogenic component, that one gene defect for these patients happens in about 20% of those very early onset IBD patients. So we do advocate to do genetic testing for these patients when they're diagnosed less than 6 years of age. And that's compared to like older children with IBD who are more around the 3% where you'll have a genetics, and we really don't know where the adult sort of aspects are. And this can have dramatic implications of treatment overall. The top right is what got a lot of press and play. These were case reports of a certain genetic defect called an IL-10 receptor defect in a subgroup of IBD patients, and they were presenting at a very young age of a year of age with distinct phenotype of their disease, and they were treated with stem cell therapy that was curative for their disease overall. Go ahead to the next slide. So we talked about a couple of unique aspects of pediatric IBD. Let's talk a little about treatment and how that treatment can be unique in the pediatric age range as well. So to start off with, let's set up our treatment goals. And our treatment goals, we have a therapeutic goal, which is to reach mucosal healing. When we look with that scope, that we see that tissue is healed up and sustaining a lasting remission that's steroid-free, and that, as I always say, that this child is being like everybody else, and you can't tell that they have inflammatory bowel disease. So the treatment of pediatric IBD patients will focus on the individual patient, and it requires a common sense approach for us with consideration of things such as symptoms, quality of life, their growth, minimizing side effects in the long run. But one important thing about PEDS is that there is a paucity of therapies that are approved specifically for children. Most of the treatment regimens that we give are extrapolated from adult studies. So we're doing off-label usage, which means that these drugs are not FDA approved under 18 years of age, and we're actually using them from adult data and giving them to kids because we need those treatments overall. Let's go to the next slide. Classically, we would always teach in the past this treatment pyramid, which is this concept that if you have a patient who's been diagnosed, that we're going to start on the lower end of these drugs that may have quote unquote less side effects and move up depending on the severity of the disease. What happened there was that we saw a lot of complications of the disease and not enough success in terms of treatment. So several years ago, this was turned upside down with this concept of what's called top down, starting at the top and coming down the pyramid, where patients should get the heavier treatments early on to change the natural history of the disease overall. Now, in this day and age, what we'll talk about is moving on to our newer thinking, which is a precision-based, individualized, personalized approach for treatment overall. Next slide. The reason why we're in that era right here is that here's two patient examples to look at overall. These were actually clinic patients of mine. And if you look at their clinical history that you see in that left column over there, they're pretty much identical in terms of how they were presented. They were both 15-year-old male. They both presented with similar symptoms, diagnosed with Crohn's, that were located in relatively the same areas overall. They were both started on infliximab, an anti-TNF treatment for their disease, which is approved for pediatric Crohn's disease. The dose was optimized for both of them, and both of them saw response, clinical and biochemical, meaning they felt better and their blood work and stool parameters all were improving. But when we look to see had they healed their tissue overall after their treatment, after optimization of therapy, what you see is that rightmost endoscopy pictures where the top patient still had the ulcerations nearly similar to what he started with in the middle column. and the bottom patient responded overall. Why is that the case? These two are very similar, but yet one responded beautifully and the other one did not overall. And that's the problem with that pyramid approach and why we need to personalize the decision, personalize the treatment approach for each of these patients. Go ahead to the next slide. The other aspect of it is that if you even look at the adult studies that have been approved for treatment of IBD, whether it's adalimumab, infliximab, vedolizumab, ustekinumab as examples of those treatments overall, and you look at actually what the success was in the clinical trials that led to the approval, you can see the numbers of patients who reached the remission, the endpoint that we wanted, somewhere in the ballpark of 20 to 30%. Now, that did a lot better than placebo, so that's why these drugs are approved, and we celebrate that overall. But it also means that 2/3 of our patients are not reaching that endpoint of remission. So we're missing the mark on those. And then what you run into is complications of their disease, and you see that in the top graph where they start developing scarring or fistulas and penetrating disease and so forth. Go ahead, next slide. So really that brings us to this day and age of how we pick treatment. And in this era of precision personalized medicine, the phrase that we always use is choosing the right therapy for the right patient at the right time. It's an individualized discussion that you should have with your provider and understanding who you are, what your disease is, where you're at, and how that's going to influence how you're going to choose what therapy you want. Go ahead, next slide. So that could mean using certain diets as primary treatment or as adjunct treatments to your medical treatment overall. That could mean diets such as exclusive enteral nutrition, where you're drinking formula 100% of the time, partial enteral nutrition, or other diets that you may have heard of, like specific carbohydrate, Crohn's disease exclusion diet, adding in the Mediterranean diet as an adjunct therapy, or even doing something called the IBD anti-inflammatory diet. Again, you want to personalize this for who you are, where your disease is, right patient, right time, right treatment. Go ahead, next slide. Now, when we talk about medications overall, you can see that the breadth of medications that we have, and this slide is even 4 years old, that there's more drugs to treat and has dramatically increased over the last 20 years. When you look at the first 70 years of treatments, we had a handful of treatments. And now in this era of advanced treatments, biologics, and small molecules, we've seen many, many more medications with different mechanisms of actions. Again, so important for us to pick the right treatment for the right patient at the right time to understand who's going to respond to what therapy when. Go ahead to the next slide. So if I look at all the currently approved IBD drugs that Adam and Haley can choose from in the adult world, this is a list of those in terms of the traditional therapies of steroids and aminosalicylates and immunomodulators to the biologics that started with the TNF inhibitors and goes to other sort of anti-antibody drugs where the IL-12/23s or the IL-23s to the integrin receptors to now the small molecules with the JAK inhibitors and sphingoside 1-phosphate inhibitor. Big list of different drugs that we need to choose from and have a different menu of, again, different working mechanistically, and we want to choose the right therapy for each individualized patient that we think they will respond to the best. Go ahead, next slide. But specific to pediatrics, the only two approved pediatric drugs are the anti-TNFs. So that is infliximab and adalimumab. Infliximab being an intravenous medication, though now there's a injectable form of it as well once you've been on the intravenous for a bit. And then adalimumab is a injectable form of an anti-TNF drug. And these drugs are approved in both pediatric Crohn's disease and ulcerative colitis in various fashions of the different disease phenotypes. And the bottom left is the original clinical trial data that led to the approval in pediatrics for Crohn's specifically there overall. Next slide. But bringing it back full circle, one of the things I told you about that was specific to pediatric inflammatory bowel disease is height issues overall. So this is one of those right phenotype things that we will consider when we're treating patients overall. Was height affected by their disease? Could that influence what treatment we choose? And yes, that's something that can be influenced, because if you look at the data from infliximab from the original clinical trials, and adalimumab as well, what you see is an improvement in height velocity. Children who were shorter than they should have been now all of a sudden sprouted out to where they should have been thanks to this type of treatment overall. Next slide. The next slide shows you actually this in real life. This is a patient of mine right here, and you can see that this child was diagnosed around 10 to 11 years of age at that point and was growing substantially lower when they were predicted to be. That little bubble on the right between the 50 and the 75th percentile is that mid-parental height right there. And by getting them on the right treatment, in this case, the anti-TNF right there, you can see that dramatic improvement in their height velocity, which is such a big factor in their overall health in the long run of how they feel about themselves and how they interact with their world, but represents how well they're doing from a disease perspective. Next slide. So I think just to kind of wrap it up, the question is, in this approach of right treatment, right patient, right time, are we making a difference? If we tailor our treatments, can we reduce those complications that we kind of briefly broached on overall? And we're starting to see evidence that we can. So it's two examples here. One on the left side is the RISK study. The RISK study was the largest prospective multi-center natural history study of pediatric Crohn's disease. It was the first ever done. We were one of the participating sites in the center, and what it looked at was children for over 7 years post-diagnosis of Crohn's disease, and allowed the centers to treat the patients the way they did. And one of the findings within the RISK study was that those patients who received the anti-TNF therapy earlier on actually had less risk of certain complications of their disease, specifically penetrating or fistulizing disease overall. But that didn't make a difference. That same treatment did not make a difference for stricturing or scarring. So we got to figure out different ways of how to influence that overall. And then on the right, you see a recent study that looked at rates of colectomy in ulcerative colitis patients, removal of the colon in ulcerative colitis. And you can see that in the pre of our current biologic treatments to the post-biologic treatment era, we've seen a dramatic halving, a reduction from 18% to 9% of those colectomies overall. So you are seeing a change in the history of these patients and the difference in outcomes overall. Next slide. So I'll put forward for you our view of how we look at it as the conclusion for this portion of this discussion right here, where we do believe in this precision approach to IBD, and that helps us in terms of targeting our therapeutics overall. So we get away from the classic Crohn's and ulcerative colitis, and we start grouping patients by different characteristics of who they are, whether it's based on their genetics, their microbiome, the way their disease presented, the complication of the disease, and that's going to influence how we select, what treatments we select over time. If you go to the next slide, so what you could see as a future would be that the patient visits their IBD physician, they get diagnosed with IBD, they're coming in, and their samples are analyzed through different panels of blood work, microbiome studies, their whole clinical history is put together, and through that, then we can generate some sort of composite score that tells us where they are relative to the prognosis of their disease. Whether they're mild to severe, and how that's going to influence what kind of treatment we offer. And then if you look at that menu of therapies, then what we can pick and choose is diet, medications, microbiome changes overall, and putting these all together, we can come up with what the right regimen for the right treatment for the right patient at the right time would be, leading to more earlier interventions with individuals, more durable treatments, and hopefully preventing progression to severe IBD. So try to give you a little taste of these various things, and I'll sign it over to Adam to talk to you about more adult-focused stuff.
Sounds good. Thanks so much, Shervin. And I really agree and just want to echo those sentiments that, again, this is a very individualized approach. But what I'll be providing and what I was really tasked with is how do we manage wellness as we're aging with IBD on the other end of the life spectrum? So as we're getting older. And so I'll really provide that 10,000-foot view of how I think about it. So we can go on. So a lot of my research and area of interest focuses on aging with inflammatory bowel disease. And I do a lot of research on frailty and sarcopenia and the development and really trying to mitigate that as we're getting older with inflammatory bowel disease. So this is just a slide to show you the prevalence of inflammatory bowel disease in the US. So I think classically, we used to think of it as a disease of individuals who are very young. But actually now we're starting to see a much larger proportion of the individuals, both globally, but also here in the US, are actually older with inflammatory bowel disease. So probably about 1/3 of all individuals with IBD are about 60 years or older. And that really comprises two main cohorts. So one is the individuals who develop IBD later in life. And I think I saw a question about that. So that's about 15 to 20% of all individuals with IBD. And then we have all of our younger individuals who are now aging with inflammatory bowel disease. And maybe they were diagnosed at 25 or 30, and now they've had disease, like Ari was mentioning, for 30 or 40 years. And how do we really approach that? We can go on to the next slide. So I boiled it down again, 10,000-foot view into my at least top 4 tips I think about when I talk to my patients for healthy aging with IBD. And Shervin talked a little bit about this, and so I'll briefly mention diet. Again, there's no specific diet for individual people, meaning this is really global studies that have looked, and it's not a personalized approach. But what I'd like to highlight is that we're learning a lot more about diet. So we do think that diet does have anti-inflammatory properties. Shervin mentioned those exclusive enteral nutrition diets, which tend to work in pediatric patients with Crohn's disease. I think a lot about the Mediterranean diet. There was that nice study, the DINE-CD study showed below, which Shervin mentioned as well, where they randomized individuals to either having a Mediterranean diet or a specific carbohydrate diet. And they actually have a lot of overlap in them. And it's basically minimally processed plant-based foods, as you can see in the image on the left there. They're rich in monounsaturated fats, so olive oils, fish, fruits, vegetables. And they not only, what you think at least, have a lower inflammatory burden, so helpful for IBD, but also they have systemic benefits. So when you look at cardiovascular health, so we're talking about blood pressure and weight and cholesterol and glucose levels, these types of diets actually tend to have positive benefits. Again, outside of just the inflammatory burden for IBD. So when I talk to my patients and I send them to speak to our nutritionists, I often mention the Mediterranean and other diets as being kind of one key principle. There's also good data, at least within the IBD patient population, that Mediterranean diet and some of these other diets, not only can they potentially be associated with lower inflammatory burdens, but they can actually improve symptoms and quality of life. So certainly, again, I counsel my patients on this and the importance of at least trying to adhere to these diets, not only for IBD, but also for good overall health. Okay, we can go to the next slide. Okay, number 2. This is something that's very important and crops up often, time and time again in the geriatric literature. And as we age, staying physically active is critical. I really can't emphasize that enough. Ensuring that we're getting out for walks, runs, keeping in good cardiovascular health really does combat frailty. And I'll come back to that principle of frailty. So we all know about physical activity, but I'm going to pepper in some data and then tie it into IBD a little bit at the end. So what does physical activity do? Well, it reduces stress and anxiety. That's great for a lot of things, but we actually know, based on recent data, that stress and anxiety can actually trigger flares of inflammatory bowel disease. So reducing stress and anxiety is incredibly important. It can enhance sleep. It can also reduce falls and injury as we age. And I think someone had mentioned osteopenia and bone loss, which we'll talk a little bit later on. But again, ensuring that we have good overall musculoskeletal health and good cardiovascular health can actually help prevent these things. And then 4th, which is the data I'll pepper in, is that beyond just IBD, overall, in our aging patient population, it actually is associated with reduced mortality. So if you look at this study here, MPA at the bottom left, I don't know if you can see my arrow, probably not, but if you can, at the bottom left, at the intersections of the graph, that's moderate physical activity. And then if you look at the box to the right, that's vigorous physical activity. And so if you look at the moderate physical activity for 0 to 19 minutes, so you're not doing much moderate physical activity, the more vigorous physical activity you do, your lower mortality. So the more vigorous activity, again, you lower your mortality over time. As you pick up more and more moderate physical activity, so if you look all the way to the right now, 300 to 599 or greater than 600 minutes per week, the vigorous activity doesn't matter so much. So what is this all saying? It's get your exercise, whether it's going to be some vigorous activity or whether it's going to be an abundance of moderate physical activity. So Again, for vigorous, they measure it by these things called METs, which are metabolic equivalents. So running, things that get your heart rate up. For more moderate physical activity, maybe you think about calisthenics or walking. But again, doing exercise is critically important, not only for overall health, but also, I'll tie it back into IBD later, but it can lower your overall mortality and improve overall health. Okay, let's go on to the next one. So 3, cognition. So this is incredibly important as we age. So making sure that we're cognitively able to understand and go through things. So about, I think 2 years ago, there was a study, a very nice study that came out in Gut, which is one of our premier GI journals. And it showed that patients with inflammatory bowel disease may be at higher risk for dementia. Now, this isn't a randomized trial. It's just a observational study. So they follow patients over time. Now, some of that data is limited. You can imagine if you have inflammatory bowel disease, you're probably seeing your doctors more often. So it's probably more likely that you may be diagnosed with some memory loss or cognitive loss earlier than individuals who maybe aren't seeing their doctors so often. So keep that in mind. But what they found was that overall, about 5.5% of individuals with inflammatory bowel disease developed dementia versus about 1.5% among individuals who didn't have inflammatory bowel disease. And when they looked at the timing of it, patients with inflammatory bowel disease develop dementia about 6 to 7 years earlier. Again, that may be because they're more frequently going to see their specialists and physicians. But it gets us at least thinking, if that's even plausible, maybe it's not as wide of a gap as we think, but maybe there is even a slight gap there. How can we preserve cognition? How should we be preventing it? So as we age, these are things to think about. So we can go to the next slide. So what's important, and this is probably not something new to you, you've probably read about this, stay cognitively engaged. It's incredibly important. The National Institute of Aging, where I'm funded from my research, has very good data showing that this actually helps. So older adults who learned a new skill, whether it be quilting or photography, they actually had better memory improvement. If you engage in activities like music or writing, it can increase social engagement. It can reduce stress. Again, we talked about the connection between stress and IBD, and it can improve memory. And there's a very interesting trial now being done. So if you look at the schematic at the right from the National Institute of Aging, where they're taking a population of older adults and they're basically priming them. So they're randomizing them to either a couple of sessions where you go through some memory exercises, some reasoning exercises, speed exercises, or no exercises. And they actually see, does the memory, reasoning, and speed get better over time? And actually what they found is with these interventions, it does get better. And then what they're studying is, does it actually persist? So does it quickly go out the window a year later? It actually seems like it stays there for a couple of years. And those boosters in the post-test actually help keep some of those, again, memory, reasoning, and speeds at a higher level than if there's no intervention there. So incredibly important to stay cognitively, socially engaged. You can go on. So now I'm going to tie all of those into this. And this, I think, is one of the most important things, especially for individuals with inflammatory bowel disease. And that's really controlling inflammation. And I realize that's easier said than done. And I think Shervin really highlighted and did an amazing job going through how we think about that and really ways to optimize our current treatment strategies. And I'll talk a little bit more about that. So we can go on to the next slide. Okay. So one, why is it important to control inflammation? Well, aging is actually an inflammatory state. So we actually call it sterile inflammation. When we think of inflammation, we think of it that there may be a bacteria or something else that's triggering all these inflammatory cascades. Well, aging we think of as sterile. There's no trigger. It's just as we're getting older, our cells tend to die, and some of those cells release inflammatory, what we call cytokines, which are just inflammatory molecules. Inflammation from IBD also has many of the same pathways that are activated compared to aging. So there's this idea, although we need more data, that if we have ongoing inflammation from inflammatory bowel disease, those same pathways that are activated as part of the aging pathway, it may actually compound or accelerate that aging process because you're just propagating more of those inflammatory cascades that are upregulated. Okay, so that's reason one, we think it's important to control inflammation. Two, we know corticosteroids are great for controlling inflammation. We do have to use them at times, hopefully for short periods and not for longer periods. And the reason is, if we can control inflammation, we can reduce the likelihood of needing corticosteroids. And long-term corticosteroids really do have quite severe adverse effects that persist over time. So what do? Well, they can reduce quality of sleep. They can cause anxiety and mood disturbances, again, pulling back that stress and IBD flare trigger. And then you can start to accumulate comorbidities. So over time, steroid use can lead to bone loss. So we talked a little bit about osteopenia and osteoporosis, and it can also lead to diabetes, cataracts, all things associated with aging and other comorbidities. And it can also increase risk of infection. So again, ongoing inflammation will increase the likelihood of needing corticosteroids, which also may accelerate that aging pathway. Okay, we can go on to next. Okay, number 3 for this. So ongoing inflammation can limit dietary choices. I talk to this with my patients all the time. They always say, am I going to be able to have my coffee again? Will I ever be able to eat vegetables? It gives me bloating and pain. And what I say is, ideally, yes. Once we control the inflammation, you should be able to do the things that you used to love to do. Eat those vegetables, drink the coffee, and so forth, right? So if you're having ongoing inflammation, a lot of things that normally you would be eating, whether it be dairy products, vegetables, you may not be able to process quite as easily, and it may give you a lot of symptoms. So with ongoing inflammation, you're probably going to make dietary choices, rightfully so, that make the intestinal tract and your symptoms minimal. But in doing so, you may not be choosing the Mediterranean diet, right? Or you might be developing micronutrient deficiencies because you're keeping more to tea and toast to try to keep symptoms at bay. So again, controlling inflammation now may actually help broaden your diet, allow you to eat the Mediterranean diet, the specific carbohydrate diet, introduce some of those fruits and vegetables that maybe you weren't before. Another aspect is staying physically active. You can go back for 1 sec. So for me, I think this is one of the key points, especially as we're aging and getting older. There's a classic principle in geriatrics where we say, as we get older, for every 1 day in the hospital, it actually takes about a week to recover at home. And so what happens when we have ongoing inflammation is we have urgency, we have abdominal discomfort, we don't want to go out, we tend to sit in the home. That moderate and vigorous physical activity, we're not doing it because we're tied to the bathroom, or we have symptoms, or we don't feel well enough to go out and do things. And then so that leads to reduced physical activity, which can lead to frailty over time. And again, we'll talk about frailty in a minute. So what about ongoing inflammation? It can also limit cognitive engagement in very much the same way that it limits physical engagement. So if you're not going out and you have your weekly friend night or doing things and staying cognitively engaged, this is again a way in which inflammation can contribute to cognitive decline, or maybe even a desocialization over time. So again, controlling inflammation keeps you physically active, it keeps you cognitively active. I talk about with my patients a lot, we not only have to feed our bodies the right nutrition and keep them healthy with exercise, but we also have to be doing the same for our brain. And I tell my 4-year-old this, that brain is a muscle, we have to use it. Okay, so all in all, the whole idea is that ongoing inflammation based on all of these things, so physical activity, cognition, dietary choices, all these things can increase the likelihood of progressing to frailty. And frailty is really this state of increased vulnerability. And so usually when we're younger and we have what we call homeostasis, which means all our physiologic systems are working pretty well, if we have a bump in the road, we get a cold, we get sick, we're usually able to recover pretty quickly. With ongoing inflammation and all these other factors, what happens is once we have these insults, if we have a flare or something else happens, if all those other homeostatic conditions are not stable, what happens is we tend to go down a decline and we actually don't recover to the baseline. And I'll show you that on the next slide. But before we go to that, I'll highlight this study that was really nicely done in the box to the right. So what you can see here, this is about a 1,200 patient study, I believe. And it's all aged individuals with inflammatory bowel disease. And they looked at the development of frailty. So again, that vulnerability to stressors over time. And what they found was that if you responded to your treatment only 7% became frail over time. And if you didn't respond to the treatment, meaning you have ongoing inflammation, 27% or more than a quarter of patients became frail over time. And interestingly, there's been some other data, not only with inflammatory bowel disease, but in other conditions like heart failure, where individuals who are frail from their underlying disease, whether it be IBD, heart failure, rheumatoid arthritis, treating that disease can actually potentially reverse the development of frailty and even mitigate it. So we can go to the next slide. So this is essentially how I put it together, and this was a paper that we had recently published. So essentially, I think of treatment of inflammation as this window of opportunity, which we often talk about in an IBD. Shervin mentioned this as well, early and effective treatment controlling that inflammation. And so you can see as you have the stressor, you may come back and rebound to that wellness baseline, but you may have decrements over time. Now, if you follow the green line, if you have resolution of IBD-related inflammation, so again, maybe you're able to liberalize your diet, you're cognitively staying engaged, you're physically active, you don't have all those inflammatory markers, you actually may delay or even mitigate the development towards frailty. But if you have ongoing inflammation, and so you're not going out and you're physically not staying active, you're cognitively not staying active, you're maybe not eating the diet that your body or that you wish to be eating, and all those inflammatory cytokines are kind of propagating that aging inflammatory cascade, you may actually progress a bit more towards frailty. And you can see as you go on, it gets harder and harder to rebound to that baseline spot. Okay, we can go to the next. So I will sum up essentially the 10,000-foot view of how I think about healthy aging. So all this is really focused on prevention. So again, it's not just applicable to our older adults with inflammatory bowel disease, but even our younger patients who are thinking, okay, you know, I have now this for 30, 40 years. How do I age in a healthy fashion with this disease? So one, again, think about diet. Again, one size doesn't fit all. I think Shervin pointed that out very nicely. So this is really just a 10,000-foot view, but something like the Mediterranean diet can improve symptoms and quality of life. It's not only potentially a lower inflammatory burden for IBD, but it can also reduce other comorbid conditions. So it's good for cardiovascular health. It has other systemic benefits. Physical activity, it improves stress and anxiety, which we know are flares for IBD, helps with sleep. It can reduce falls or injury. Again, from the steroids, we may be more prone to falls or injury, and physical activity can actually help prevent that. It can also, physical activity has been shown to improve longevity. Again, the more physical activity you did, the lower your mortality, and it can reduce the development of comorbid conditions. Stay cognitively and socially engaged. It can improve your memory. Maybe it'll reduce the risk of dementia. We don't know. We need more work there. There's also downstream effects. If we stay cognitively and socially engaged, as we get older, we tend to pick up comorbidities, diabetes, cataracts, and we tend to need more medications. And so if we stay cognitively fit, we can tend to manage those medications a bit better. We just published a paper that came out maybe about a week or two ago showing that the more medications we prescribe, the more likely it is to actually have a hospitalization within the year. And it makes sense. When you line up 10 pill bottles, I'll probably forget which one I'm supposed to take 4 of today and 1 of tomorrow. And that can lead to medication interactions and so forth. And then 4, and I won't say most important, but one of the fundamental things with an inflammatory bowel disease is really controlling inflammation. And the reason it's so important is it limits the need for corticosteroids, which we talked about. Controlling inflammation, which we didn't mention before, but I want to highlight, can really limit adverse events that are driven by disease activity. So we often think about the medications and we focus on the safety there, but we also have to think, well, what if the disease is not well treated, or it's undertreated, or there's ongoing inflammation? That itself is a major driver of adverse consequences or adverse clinical outcomes. We need a hospitalization. I talked about needing a week to recover as we get older from that, and so forth. Also, controlling inflammation allows for diet liberalization, stay physically active, socially and cognitively active, and it improves quality of life and reduces that progression towards frailty. So with that, I hope that was a 10,000-foot helpful view, and thank you again for coming tonight.
Hi, everybody. Doctors, that was really, really great. I sit here thinking about kids and all the options that they have and all the better outcomes that I think they're going to have than when I was a kid. And Dr. Fay, I'm not so pleased about the elderly ones. I hear you go through all the symptoms. I'm going through the checklist of my own body, thinking I got a lot of work to do. So I think it's great that we got all this information out there, and it's been very helpful. We have about 15 minutes left, and I'd like to do a couple of things right now. First of all, I'd like to go back to the original question that we had, and everybody keep putting your questions in the question and answer box, but I want to go back to those original two questions that we had. The first one being IBD therapies for children, and the second one being what is the greatest number of patients living with IBD in the US? If we could put our thoughts in now after 45 minutes of listening to these doctors and see what the outcome is for that. I'll give everybody a second to do that. Okay, let's see what it came. Okay, we're up to 85% true on the kids not having things. And then on the answer to the second question is 65 to 79 is the largest group of people with IBD, and that's including my group. And I hope that a lot of the things that are happening out there now can help the seniors as well as the peds kids. So what we're going to do now is we're going to start taking some questions from the audience. Dr. Merkins is also here. She's going to be joining us to answer some of the questions. She's been doing it in the background while we've been listening to these doctors. Do we have the first question? Okay, I'm gonna ask the first question, and this is to Dr. Fay. So here I am, I'm 63 years old. I think I check every symptom box that you had out there today. What would you tell a 35-year-old me to do differently so I don't feel the way that I do today?
Yeah, it's a great question. I think a lot of the things that I highlighted, but when you're 35, I would think about early and effective control of inflammation. I really do think that ongoing, repeated courses of inflammation over time, the need for corticosteroids, but even just the inflammatory cascades that continue to occur, we don't have enough data to quite say, but it's hard to imagine that we recover fully after each of those episodes. So really controlling that inflammation early on and effectively and staying in remission, it can help physical activity, cognition, diet, and so forth. And so I think really that's kind of the key when we're younger to start thinking about, is making sure that we have early and effective therapies. And I know, again, it's not a one size fits all. That can be easily accomplished and said for some folks and very difficult to accomplish for other folks. So that comes in, a variety of different factors there. But I really do think honing in on effective control of inflammation does really mitigate that progression towards frailty. So to me, I talk about that with my patients all the time, even my younger patients, as we're talking, I line out, here's what we're going to be looking at in the next 6 months, 1 year, and 10 year, and here are kind of our goals over time.
I wish I knew you 30 years ago. Okay, here we go. I'm going to start asking a couple of the questions here. This is from Carol. I'm 72 years old. I have a 52-year history of Crohn's disease. I cannot exercise due to pain in my back from osteoporosis. I do PT 3 times a week. My skin is destroyed from steroids. Is there any hope for me? Who'd like to tackle that one?
I'm happy to tackle. There's always hope. So, it may not mean riding a bike right now, running a marathon, but I think staying physically active in any way possible. So doing physical therapy is incredibly helpful. You can do, again, easier said than done, but getting into the pool, doing exercises or water aerobic exercises. I even showed on the mortality slide, it doesn't have to be that vigorous activity of running and getting your heart rate up and going up 20 flights of stairs. Even doing moderate activity, whether it's, 20, 30-minute walks, things like that. And again, I realize that that may be difficult and something to build up to, but anything is better than nothing. So if you can work with physical therapy, if you can do a little bit more each day and so forth, if you can stay socially and cognitively engaged, If you can liberalize the diet a little bit and try to stick to something like the Mediterranean type diet, I all think even limited changes, limiting the stress, these can all have very positive downstream effects, and you can build on them over time. So I do think, I never say that there's no hope. It's just about goal setting, and we hit one goal and then we move on to the next.
Hi, Gary. This is Kat. I just wanted to alert you that the questions are in the chat box directly to you, so you can feel free to pick those questions. Thank you.
Oh, okay, great. Thank you. This is from Christy. How would you define prolonged use of steroids, and what is considered a high dose for steroids?
I'm happy to. Anyone can jump in. I mentioned it, so I'll just say there's no strict definition. I talk about this when I talk about a lot of medications with my patients, but I say I try to use the shortest course and the lowest dose of steroids needed. I talk about that a lot with what we call our NSAIDs, or non-steroidal anti-inflammatories like Advil, Aleve, which we think can precipitate flares too. So the lowest dose that we can use for the shorter amount of time is always best. Sometimes we do need higher doses and more prolonged. Usually we start to think about higher doses like 20 milligrams of prednisone up to about 40 milligrams. Sometimes people go to 60 milligrams, but not that often. Those are really the higher doses. Longer courses, maybe around 30 days, but there's no strict cutoffs. Essentially, if you need to use them, it's okay, but the shortest course with the lowest dose possible is really what I aim for, strive for, and that's how I kind of think about it.
Okay, here's a question from an anonymous attendee. I've been denied the shingles RX vaccine multiple times, even though my gastroenterologist recommended it. I've been told I am too young. Is shingle RX recommended for all adults with Crohn's disease?
Adam, you want to take it? I mean,
I was going to say,
opinion.
unless you wanted to, because it sounds like it's more on the pediatric side of things.
I'm
The
happy
older
to.
adults, it's actually easier.
So we do recommend it for anybody over 18 years of age. We would recommend that if you can obtain it. The difficulties you're having are commonly experienced by many, but keep up the good fight to try to get it in the end.
Okay. Another question that I think is a timely question is, we've got a wave of COVID coming back across the country. What are your feelings on COVID, and in particular long COVID and Crohn's patients?
So we've done a substantial study here looking at COVID across multiple years of it overall, and some of the basic conclusions, or the big view conclusions, are that we don't see it as a significant factor in compared to other viruses or infections in terms of what it does to our patients with inflammatory bowel disease. We don't see it an issue in terms of the medications that the patients are. We're not seeing a higher rate of COVID infection secondary to most of the drugs that our patients are on overall. We do recommend vaccinating. Seems that that's protective, and we would advocate for that overall. In terms of long COVID, I haven't seen much in terms of any sort of differentiation with IBD.
Okay. Here's an anonymous question. I was diagnosed with UC at the age of 2 in 2002. I'm now 24 years old, and I'm wondering, is there any data that exists for VEO IBD, and how that the different stages of growth are impacted by the disease progress, and ultimately the prognosis as the individual grows up with IBD?
Yeah, I mean, I think it's a great question. So broached a little bit about it when we talk about the VEO IBD patients. The younger you are that you're diagnosed overall, that's a risk factor for severity of disease. That doesn't mean that everybody is going to have more disease or more significant disease or more complications of the disease, just something that you want to make sure that you know in the back of your head. So you're always being evaluated, being monitored, being followed, and being treated in some fashion. That said, that just because you were diagnosed at such a young age doesn't mean that you aren't going to be successful with the treatments and do incredibly well and be healthy overall. So you just got to keep getting evaluated and continue with your doctor's recommendations.
Okay. All right. Okay, here's one that every Crohn's and UC patient would love to ask, but probably is too embarrassed to, so I'll ask it for all of us here. I have excessive gas. Do you have any advice or solutions so that I can go out in public again?
I can tackle, or unless Haley or Shervin, you wanna.
Go for it.
Okay, it's a great question, and it comes up, like you said, Gary, all the time. To me, it boils down to a little bit of figuring out what exactly is the cause. So first and foremost, is there still ongoing inflammation? If there is, really try to tackle it. Now, assuming that there's no ongoing inflammation, you still have it. Is it that there are certain fruits or vegetables that are triggering it? And sometimes the nutritionist can help that. There can also be other associated conditions like SIBO, which is small intestinal bacterial overgrowth, which sometimes our patients with inflammatory bowel disease are more likely to get, and that can require a little bit of a 2-week treatment with something called rifaximin. There's also other things I consider, so I make sure that there's not celiac disease, right? So we know that autoimmune, or what we call immune-mediated diseases, tend to go together, and so making sure that there's not concomitant celiac disease that we're missing, excuse me. Otherwise, just simple things. You can always try a gas X, right, which is simethicone. You can try it before a meal if you know that a salad or beans are things that tend to trigger that. You can try that. Try cooking the vegetables a bit more. You can try things like Pepto and so forth, but it's really kind of a partnership to go down the line and try to figure out, is it a dietary thing? Is it an undiagnosed celiac? Is it that SIBO I was mentioning? Is there still ongoing inflammation? But it's like you said, Gary, it's probably comes up in 1 out of every 3 visits because it's an incredibly, common and important conversation that we need to keep having there. And there's not always an easy answer or solution, but I think that's kind of how I approach it, at least initially. I'm not sure if Haley or Shervin have other approaches also.
Okay. All right. I'm going to ask the last question here, which is an optimistic one from an anonymous attendee. Have you ever seen a case of Crohn's disease that burns itself out after having it for so many years?
That's a great question. And I'm very interested in doing this study because the only data we have really is this 1980 survey, which showed that most patients, and this was again before a lot of our therapies, most patients within the first year had a similar proportion that were having flares or requiring some kind of therapy to 25 years later. So it suggests that the disease does not burn out over time. Now, this is the problem with ecological or 10,000-foot views, is that globally you look at that, but on individual patient levels, like Shervin was saying, it's a completely different story. So there are absolutely patients where it does burn out over time. Who those patients are, can we predict them? Can we know? That remains to be seen. What proportion actually burns out over time? We don't know. But again, the 10,000-foot view, it seems that it persists, but we certainly have patients where it does burn out over time. It's a $1 million question. It's a great question.
I agree with Adam completely. And I would just add that I think he's got the right perspective, right? So everybody thinks about the extreme of disease worsening, but there's others that will improve as well. So it's a spectrum like everything else.
Good. Well, I'm going to wrap it up. We've got about 2 or 3 minutes left. I want to wrap it up. I can't thank you guys enough for doing this. There's so much information that you came out, and I think if nothing else, I think the people on this call should come away seeing that the medical community is bringing us a lot of hope. There's a lot of stuff going on. There's a lot of research out there, and things are improving every year. And I think that as time goes on, this will be a chronic disease that you live with and you go on with your life. And I'm excited about that. So thank you very much, doctors, for everything that you're doing. The Crohn's and Colitis Foundation is got a ton of resources for everybody to use. And the foundation would like to thank everybody for being on this call tonight. Additional resources that we have where you can learn everything that we talked about this evening include the foundation's website, where we have a whole section on pediatric patients, and we have a lot of information for senior wellness. The IBD Help Center is here to provide information and resources to patients, caregivers, healthcare providers about inflammatory bowel disease. They're also available by phone and email on Mondays, Tuesdays, and Thursdays. There are support groups in many of our communities. You should look into those. There's a QR code on the bottom right-hand corner of your screen right now, so you can click on that. And finally, to watch previous webinars and expert conversations, please visit Crohn's Colitis Foundation.org, MyIBD Learning. Foundation really does have an incredible wealth of information. I found it extremely helpful to me over the last 25 years. So once again, I'd like to thank our expert presenters. You guys were awesome. Can't thank you enough for your time and your knowledge and everything that you do for the IBD community. It's just really great. And thank you, everyone, for signing on tonight. And look forward to our next IBD support in going out in the future. So thank you very much, everybody. Good night.
Thanks for having me.